Welcome back, my dear students. This is Dr. Magdi Hassan. I am back to continue the subject we started. Abnormalities of amniotic fluid volume. We have finished already the diagnosis of polyhydramnios, both clinical and instrumental. What are the complications expected from polyhydramnios at both maternal and fetal levels? Maternal complications can occur either during pregnancy or during labor. During pregnancy, the amniotic membrane may rupture before the onset of labor. This is what we call premature rupture of membranes. The patient may go into premature labor. The patient may develop acute infection of renal pelvis and urinary passages, that is to say pyelonephritis. This is because of the pressure exerted by the hugely distended uterus on the renal pelvis, causing urinary stasis and infection. Malpresentations and malpresentations are common, like breech presentations or transverse lie. This is beside the pressure effects. During labor, the over-distended uterus may fail to contract and goes into uterine inertia or flaccidity. Of course, this will be followed by atonic postpartum hemorrhage. The rupture of amniotic membrane during labor with the sudden escape of the fluid results in sudden drop of intrauterine pressure. This may cause sudden premature separation of the placenta, accidental hemorrhage. The umbilical cord may also escape through the cervix. This is called cord prolapse. An amount of the amniotic fluid may reach the circulation with its contents of cellular debris, hairs, and other particle, thus causing a type of embolism called amniotic fluid embolism. Fetal complications of polyhydramnios include 1. Complications related to the etiology. That is to say, the effects of the congenital malformations, complications of infant of diabetic mother, or the sequelae of Rh isoimmunization. 2. Fetal prematurity when born before the lungs are fully mature. 3. Intrauterine fetal death or stillbirth due to labor complications. To put a plan for management of a case of polyhydramnios, the obstetrician should consider the following points. 1. The severity of the pressure symptoms. The severer the pressure manifestations, the more urgent is the need for delivery. 2. Gestational age and fetal maturity. The hope will be always to reach fetal maturity if possible. 3. Associated congenital anomalies. A considerable number of cases are associated with congenital fetal anomalies. The type of the anomaly, if present, may affect the decision of continuation of pregnancy. Generally, the choice will be one of the two plans. Either conservative management, which means continuation of pregnancy hoping for fetal maturity, or active management, which means immediate termination of pregnancy if the continuation is risky or hopeless. The conservative management is chosen for cases with mild to moderate pressure manifestations, premature baby, and when the baby is healthy, non-malformed. The patient may be given nonsteroidal anti-inflammatory drugs, especially indomethacin. It is claimed to be able to limit the rate of amniotic fluid production. However, it carries the risk of premature closure of the fetal ductus arteriosus, and the baby may develop heart failure. An amount of the amniotic fluid may be drained by a procedure called amniocentesis. This will be discussed in the face-to-face session. The patient is nursed in a semi-sitting position to alleviate the respiratory pressure effects. Fetal lung maturity is to be induced for fear of premature delivery. The active management or the immediate termination of pregnancy is the choice in any of the following cases. Severe cardio-respiratory pressure manifestations. If the baby is mature, or if it's severely malformed, incompatible with life, at which situation no hope of conservation. Termination will be either vaginally through induction of labor, or if contraindicated, a cesarean section will be needed. The other extreme amniotic fluid volume abnormality is the severe decrease, which is called oligohydramnios. It is defined as the pathological reduction of the amount of amniotic fluid. The expression pathological reduction is defined as A volume less than 200 milliliters at any gestational age. An amniotic fluid index less than 6 centimeters. Or the deepest vertical pocket less than 4 centimeters. Causes of oligohydramnios are again fetal or maternal. Fetal causes include 1. Fetal urinary tract malformations, causing either decrease in urine production or failure of fetal urine to reach the amniotic cavity. Renal agenesis, where urine is not secreted. Urinary tract obstruction like urethral stenosis, urine does not reach amniotic sac. 2. Severe intrauterine growth retardation, a very small baby of course participates less in the formation of amniotic fluid. 3. Post-maturity syndrome, the post-mature placenta develops atherosclerotic changes that minimize the amniotic fluid transudation. The mother can be the cause of oligohydramnios if she has a maternal diseases that impairs the placental functions like hypertension. By far the commonest cause of oligohydramnios is the premature rupture of fetal membranes and escape of the amniotic fluid. A patient with oligohydramnios usually notices that her abdomen is smaller than expected and the fetal kicks are decreased as the baby is deprived of its ability to move and kick freely. Abdominally, the uterus is felt smaller than the gestational age. An ultrasound examination is a crucial step in the management. It can confirm the diagnosis of oligohydramnios through reporting the deepest vertical pocket at 3 cm or less and amniotic fluid index at less than 6 cm. Ultrasound examination can also be useful for diagnosis of the cause. Fetal growth curve will show growth retardation. Doppler ultrasound can estimate the sufficiency of placental function and diagnose the degree of placental insufficiency if any. A case of oligohydramnios, if neglected and not properly managed, can end in disappointing complications. The severe decrease in the amniotic fluid volume will lead to compression of the intrauterine contents by the muscular uterine wall. The fetal body will suffer this compression as well as the umbilical cord. When fetal limbs are compressed, the joints are disfigured, leading to talipes. The lungs fail to inflate, resulting in pulmonary hypoplasia. Bands of adhesion develop between the opposed surfaces of the amniotic membrane which are nearly adherent. These bands run across fetal limbs and may encircle a limb or part of it, interfering with blood supply. This sometimes ends in spontaneous amputation of a toe or a finger. During labor, amniotic fluid, when adequate in amount, is supposed to protect the intrauterine contents from compression by the contracting uterine wall muscles. In oligohydramnios, uterine contractions can compress fetal head, the umbilical cord and its vessels, and the vessels within the myometrium. These lead to fetal deceleration and intrapartum fetal distress with threatening fetal death. Management of a case of oligohydramnios starts by treatment of the cause. Intrauterine fetal surgery may be needed for correction of urinary outflow obstruction. The patient is given antiplatelet therapy and sometimes anticoagulants as a trial to improve placental functions and perfusion. Fetal lung maturity is enhanced by steroid therapy. A maneuver called amnio-infusion is tried as an attempt to replace the deficient amniotic fluid. This will be explained in the face-to-face session. Pregnancy will be terminated at or as near as possible to fetal lung maturity, or if the volume is extremely reduced and the major fetal morbidities are impending. Thank you.